Good morning, students. Today we will see a syndrome known as Sheehan syndrome. The name may be unfamiliar to you, but you might have heard it while taking the class of PIH or antepartum hemorrhage. One of the complications of PIH and antepartum hemorrhage we may say about the Sheehan syndrome. Today we will see what is a Sheehan syndrome. During pregnancy, complications such as BPH, hypovolemic shock may occur, leading to decrease in blood supply to the pituitary gland, mainly anterior lobe, causing necrosis of anterior lobe. Pituitary gland produces hormones that oversee the functions of our body, other glands. That is why it is nicknamed as the master gland. This gland is more vulnerable to injury during labor because it grows bigger during the pregnancy. Enlarged pituitary gland is vulnerable to ischemia and does not have ability to regenerate after the delivery. When the pituitary gland does not work as it should, the gland it controls, including thyroid and adrenal glands, cannot release enough of their hormones, affect the production of pituitary hormones. Partial or total hypopituitarism developed with necrosis of the pituitary gland leads to a rare but life-threatening condition is known as Sheehan syndrome. Symptoms of this disease sometimes start after childbirth or they can come on years later. Inability to lactate after delivery and development of amenorrhea are classical features. The aim of Sheehan syndrome treatment is to replace the missing hormones and to restore the endocrine homeostasis. It is important to replace the patient's sexual hormones as part of treatment before menopause and replacing GH for the giving better quality of life. How soon the diagnosis is made and how promptly proper treatment is initiated, the prognosis will be excellent. Its frequency is decreasing worldwide and it is rare because of hypopituitarism owing to advanced obstetric care. Definition: Sheehan syndrome, otherwise called as Simmons syndrome or a postpartum hypopituitarism, postpartum pituitary gland necrosis. It's a rare condition that affects a woman who lost a life-threatening amount of blood in childbirth or who have severe low blood pressure during or after the childbirth, which can deprive body of oxygen, which in turn causes damage to the pituitary gland. Although named after Harold Sheehan, postpartum ischemic pituitary necrosis was reported first time 100 years ago in breast gland lethargy. The incidence Sheehan syndrome occurs 1 out of 1 lakh births globally and most common cause of hypopituitarism. Incidence estimated greatly, the range of 0 to 30% of cases reported following postpartum hemorrhage. Sheehan syndrome accounts for 0.5% of all non-cases of hypopituitarism in females. The prevalence of Sheehan syndrome in India is estimated to be 2.7 to 3.9% among Paris women older than 20 years. Cause and risk factor. Primary risk factor for development of this disease is pregnancy, severe blood loss, or extremely low blood pressure during or after childbirth. Factors that may cause severe blood loss include partial placental abruption, placenta previa, large baby, preeclampsia, assisted labor. The pathophysiology: hyperplasia of pituitary gland is normal pathophysiological process of pregnancy. Increasing size correlate to increased nutritional and metabolic needs, but the arteries supplying blood to the gland remain unchanged. A large pituitary gland compresses the superior hypophyseal arteries which supply anterior pituitary with a rapid low pressure flow. The gland should return to the pre-pregnancy size within 6 months in an uncomplicated pregnancy. When PPH occurs as a resultant, hypotension and hypovolemic shock cause decline in the blood flow to the gland. The resulting pituitary gland ischemia causes necrosis of the adenohypophysis, which can be further complicated by hypercoagulable state of the pregnancy. The area of necrosis converted to scar tissue is not able to regenerate, causing the gland itself to atrophy. The result is physical destruction and dysfunction of anterior pituitary lobe. The symptoms include symptoms of Sheehan syndrome sometimes start right after childbirth or they can come gradually months or even years later. Women who have very little damaged pituitary gland might not develop symptoms for several years. Difficulty breastfeeding or inability to breastfeed. Non-menstrual periods like amenorrhea or infrequent menstruation or oligomenorrhea, weight gain, intolerance to slowed mental function, loss of pubic and underarm hair, fatigue and weakness, fine wrinkle around the eyes and lips, dry skin, joint pain, low blood pressure, low blood sugar, irregular heartbeats, breast shrinkage, decrease in sex drive. Diagnosis can be made reliably by detailed obstetric history and in the presence of lactation failure, prolonged amenorrhea, and hypoglycemic crisis. Gold standard diagnosis of Sheehan syndrome is MRI. CT scan can also help in diagnosing both MRI and CT pituitary often shows empty cellular tertica. Pituitary hormone stimulation test to check the level of pituitary hormones free T4, T3, T4, TSH, FSH, LH, estrogen, prolactin, cortisol, and insulin-like growth factor. Treatment include effective treatment of Sheehan syndrome includes treating every hormone irregularity present. Along with correcting these imbalance, consideration must be taken regarding the side effects and long-term implications of hormone therapy on various systems. Women with Sheehan syndrome are at an increased risk of osteoporosis related to hypogonadism. Hormone replacement therapy should be started as early as possible. Usage of oral contraceptive and transdermal patches were found to be effective. Levothyroxine is used to regulate the thyroid stimulating hormone. Phe-T4 imbalance is commonly treated by syndrome. Treatment of ACTH is achieved either hydrocortisone or prednisone. Corticosteroid may need to be coupled with an antipsychotic in the initial stage until cortisol regulation is achieved. Corticosteroid should always be given before initiating thyroid treatment, for the thyroid alone can cause adrenal crisis to occur. Estrogen plus progesterone hormone FSH, LH hormones should be replaced to regulate menstruation and ovulation. GH must be replaced if there is 3 or more non-deficient pituitary hormones. Replacement is achieved by a self-injection. Prognosis depends upon how soon the diagnosis is made and how promptly proper treatment is initiated. The syndrome diagnosed early and adequate replacement therapy initiated, prognosis is excellent. On the contrary, if there is delay in identifying and managing these patients, they may be present with severe and multiple problems such as adrenal crisis, symptomatic hypoglycemia, symptomatic hyponatremia, and other endocrine deficiency disorders. Thank you. Thank you for listening.